Respected senior members, my dear colleagues, postgraduates, good evening to all of you. Indeed, it is a great privilege and honor for me to inaugurate this first webinar on behalf of the TNIPS. The TNIPS is planning to host a monthly webinar on every second Tuesday between 6 to 9 p.m. Actually, the main objective for this webinar is to update the knowledge of our members and also provide an opportunity for young psychiatrists to showcase the talent in our program. So today, the theme we have chosen was the suicide prevention. We all know that World Suicide Prevention Day is falls on the 10th September, which is coming on this coming Sunday. So theme we chooses based on this World Suicide Prevention Day. We all know that suicide is a public health issue. The main cause of the death among the young adult between 18 to 29 years is suicide. It's a great concern. Death rate the suicide is greater than the road traffic accidents, especially young males, and also is greater than the maternal mortality rate in female. Recently, the government of India has released a National Suicide Prevention Strategies, that is NSPS. One of the major contributors for this National Suicide Prevention Strategy was Dr. Lakshmi Jagam Madam, one of the senior member from our TNIPS. Madam was a major contributor for this National Suicide Prevention Program. The National Suicide Prevention Program report that the suicide rate was increased in India for the past 3-4 years. Especially it was increased more in the post-COVID period. In 2017, the suicide rate was only just 10.2 per 1 lakh population. But current suicide rate was more than 11.3 per 1 lakh population. So the government of India want to reduce the suicide rate in India to near or less than 10 per 1 lakh population by the year 2030. It is possible not only if the government move, but also it needs the involvement of NGO, the mental health professionals like us, and also the professional bodies like Indian Psychiatric Society has to play a major role in bringing down the suicide rate in India. So regarding this, we have two young speakers, and Dr. Umamaheswari is from Coimbatore. Madam is going to speak about Indian data and pointers for the prevention of suicide. And another young speaker is Dr. Pradeep. He is from Salem. He is going to speak about ACT in suicide prevention. With this small introduction, I start this. I request Dr. Vikas Menon to take over the session. Dr. Vikas Menon is our the scientific committee member. Dr. Vikas, please take over the session, Vikas.
Yes, sir. Thank you very much, sir, for the introduction to the topic and for setting the things in motion. I think this webinar is important for two reasons. As you said, one is dealing with a very important topic of suicide, and secondly, it is the first in a very aspirational series of TNIPS webinars. A new series is starting today, and for these reasons, I think it's a very historic moment, and it's a privilege for me to be a moderator for the session. So before we go to the speakers, I'll invite the TNIPS office bearers. Dr. Shiva Ilangu, TNIPS Secretary, I invite him for his address.
Very good evening to all of you. It's really a great privilege to be invited for this webinar. As Dr. Pradeep, the President said, this first of a kind from TNIPS side. And I really congratulate the scientific committee to put forward a program to kickstart one of the main academic agenda by the dynamic leadership, Dr. C. MD-Salem, who has a range of plans for this forthcoming year in his tenure as president of TNIPS. So this program being as part of the World Suicide Prevention Day, certainly it's a starting process because the whole week we are planning. I think almost all the stakeholders, practicing psychiatrists in Tamil Nadu, all over India will be doing something, some sort of event to create awareness among public in terms of contributing to reducing the suicide rate across the country. So as part of it, TNIPS has done, and I really thank the scientific committee for coming up with a wonderful program with two young dynamic speakers to talk on this very important topic. So I wish the program all the success, and I'm quite happy to be part of it. And I hope, without wasting time, we will be want to hear from the eminent speakers. Thank you, Vikas.
Thank you, sir, for your encouraging words. Next, I will call upon Dr. P.P. Kannan, Chairman of the Scientific Committee of TNIPS, to give his address.
Thank you, Dr. Vikas Menon, for calling me to give you a word. Good evening, everybody. I'm really feel very happy to be part of this program, and under the dynamic leadership of Dr. Panneerselvam, our president, I think the association will reach a lot, will see a lot of heights in coming few months. This program is unique that this is first time we have initiated, and every month, second Tuesday, we have decided to organize this program. The uniqueness of this program is we plan to identify young speakers from Tamil Nadu. And whenever somebody calls me and asks me to identify a speaker, we have a lot of difficulty in, even though we know a lot of people are speaking, but it's a very difficult on my part, being academician, being in touch with many people. We have difficulty in identifying. So we thought of providing a lot of opportunities, creating channels to reach for these kind of state level programs. Hope this program would be a very successful, and the organizers, the cabinet members would be able to support and mobilize the participant, which is very important part in any program. And the program is mostly measured by means of participants. That is, number of people getting attracted to a topic and speaker. Hope all our members would provide support to the youngsters so that we will be able to take it to next level. And the topic suicide is very important, as we are in the part of creating awareness related to suicide. And our moderator already told about outreach program or more effective method of preventing suicide during his 10-second speech. And with that in mind, the topics like Indian data and acceptance commitment therapy, all these are very relevant today's context. So I expect the speakers would throw light more on these particular topics. Thank you, Dr. Vikas Menon. Over to you.
Thank you, sir. Next, it is my privilege to call upon Dr. Ramakrishnan, sir, the senior most psychiatrist in our Tamil Nadu IPS and past president of IPS Tamil Nadu as well as IPS South Zone, and presently director Atma Hospitals, Trichy, chair the session and introduce the topic. Over to you, Ramakrishnan, sir.
Thank you, Mr. President and office bearers of IPS Tamil Nadu chapter. It is a great beginning. I think it is going in a T20 mode with a series of activities, and I'm very happy. Young generation have taken up this responsibility, like Vikas, Kannan, and other people, Sivabalan. All these people are future lights of our present, right, and future lights of our Tamil Nadu IPS, and I wish them all very best to go into the national level and show our strength to all India, our all India IPS. So the topic, as you all discussed about suicide prevention, this is the need of the hour. See, every day paper you see open, there is a topic, there is this thing about suicide, and the varieties of committing suicide have also increased. And I read in a news that one fellow live, he is demonstrating a video and he is committing suicide in front of his lover, something, and for silly reason, and which we cannot explain why people commit suicide. 2 days back, I read in newspaper, one young man whose son is just mute disability. He killed all his family and he committed suicide. See, all these things are very pathetic, and we feel like crying. So it is our duty of IPS to show more about the preventive aspects of suicide and early intervention, and going to colleges, schools, and life skill management is very important for these students. And I saw in one paper, See, this is one. No place for second best in winners quota. So far, 56 suicide happened in this year. And it is not new in other parts of Tamil Nadu, major educational hubs of Tamil Nadu. So we have to find a way how to address the people, how to make them live with these failures and other things. So I think the speakers will show more light about the data and the preventive aspects. And it is a lot to be debated. And our suicide prevention committee should be formed. And many people, Karthik, they are doing very good work in our DMHP programs about suicide prevention. They are all welcome. And many Karthik should be there to spread the awareness at the root level. That is what is more important. I wish the program a great success and look forward to listening to the speakers. Thank you.
Thank you very much, sir, for your kind words and relevant messages, inspiring messages. We'll definitely try to follow up on that. So now, before I introduce the speakers, a few housekeeping rules for the participants. All participants, please kindly mute your microphones to avoid background noise disturbance. And the microphones should remain muted till both speakers have finished their talks and the meeting is open for discussion. And during the talks, please leave your questions to the speakers in the chat box. We'll be taking up those questions at the end. Try to indicate the speaker to whom you're addressing the question. For example, just say to speaker 1 question and to speaker 2 questions similarly. To the speakers, I request both the speakers to stick to their allotted time of 20 minutes. Once the allotted time is up, we'll give an indication. And once the indication is given, please wind up in the next 2 minutes or so that we can try to finish in time and everybody can have dinner with their families. So with that, I will now introduce the first speaker for today. That's Dr. Umamaheswari Vanamurthy from Coimbatore. She has done her MBBS from Madurai Medical College during 2002 to 2008. Subsequently, she did her MD-Psychiatry from the prestigious PG Mer Chandigarh in 2009 to 12. From 2012 to 15, she has worked as a senior resident at NIMHANS, and where she was attached with the Geriatric Psychiatric Clinic for 3 years. And subsequently, she has done her DNB Psychiatry and also her MRC Psych. She has several research publications to her credit, and her main areas of research interest are on suicide and addiction psychiatry. Since 2015, she's working as a private psychiatrist in Coimbatore. She was initially attached with KG Hospitals, but now she runs her own clinic that's called Mind Vision, and she has her inpatient arm at the Hull Hospital. I now invite Dr. Umamaheswari Vanamurthy for her deliberation.
Doctor, kindly unmute yourself, Doctor.
Thank you, sir. Thank you for the introduction. First of all, good evening, respected teachers, seniors, dear colleagues, and my friends. I thank the President, Dr. MD-Salem, and IPS BRS Tamil Nadu chapter for giving me this wonderful opportunity. So I'll be sharing my PowerPoint screen. So my topic for today is Indian data on suicide and pointers for prevention. So as we have discussed in the introduction, suicide is a global public health issue. Death by suicide is one of the leading causes of death globally and in India. If you see across the globe, there is almost 7 lakh death by suicide. That is, for every suicide, there is almost 20 suicidal attempt. That is, at least 1 crore 40 lakh population, they attempt suicide every year. And for every 40 seconds, there is 1 death by suicide. So if we see on the age group of 15 to 30 years, the youth population, suicide is the 4th leading cause of death among the youth and making the youth more vulnerable. Coming to the Indian scenario, this data is basically obtained from the NCRB, National Crime Record Bureau, where the data collection is from the police stations. The number of deaths by suicides are collected from the police station. And in the year 2021, as we see down in the graph, there is almost 1,64,000 deaths by suicide. So when compared to the year 2017 to 2021, there is almost 10,000 individuals are increasing every year due to death by suicide. So if we see the rate of suicide, that is the total number of suicide per lakh of population divided by lakh of population, the rate of suicide on an average is 12 in India in the last 2021 when compared to 10 in the year 2017. So there is almost a 7.8% increase in suicide rate when compared to the year 2020. If we see the state-wise distribution of suicide, the more number of deaths due to suicide are reported in Maharashtra, that is 13.5%, followed by Tamil Nadu 11%, then Madhya Pradesh 9%, West Bengal 8%, Karnataka 8%. And the number of deaths due to suicide is less in Uttar Pradesh, that is only 3% of the individuals have been reported. So if we see overall picture, about 10,000 suicide in a year have been reported in the areas which are marked in yellow. That is Tamil Nadu, Pondicherry, Karnataka, Maharashtra, Madhya Pradesh, Telangana and West Bengal. So there is a point here, that is Uttar Pradesh, the most populous state, has reported lower death due to suicide. Delhi, the most populous union territory, has reported the highest number of suicide. So maybe there is a discrimination in obtaining the data from the police station, where there is a bias in reporting death by suicide in Uttar Pradesh when compared to that of Delhi. So if we see the rate of death due to suicide, that is number of death by 1 lakh population in a year, it has been 0.7 from Bihar, the lowest state rate, to 39% in Andaman and Nicobar. So on an average, India reports 12 rate in suicide. So when next to Andaman Nicobar, there is Sikkim, Chhattisgarh, Pondicherry, Kerala and Tamil Nadu. So when compared to the Indian figure, the pointers in yellow, that is the average rate of more than 20 has been reported in Tamil Nadu, Kerala, Telangana, Chhattisgarh and Sikkim. If we see the trend in the states and union territories from the year 2019 to 2021, almost the top 5 states or union territories have been the same. That is Andaman Nicobar, Sikkim, Pondicherry, Telangana and Kerala. And the average rate has increased from 10 in the year 2019 to 12 in the year 2021. When coming to the causes for suicide as recorded in the NCRB, the family problems, it holds the highest. That is 33% of the death are because of the family problems, followed by any medical illnesses, that is 18%. So both family problems and illness, they account more than 50% of the death due to suicide, followed by substance use and alcohol, which is 6%, marriage-related issues 4%, love affairs 4%, indebtedness 3.2%, unemployment 2.2%. But the causes for death due to particular psychiatric illness have not been documented in the NCRB. So if we see the suicide victims by sex and age group, majority of the suicide victims are male, except for the age group of below 18 years, where there are more females when compared to that of males. So the male to female ratio is almost 72:27. And the most common age group where an individual died by suicide is from 18 to 45 years, which account for more than 60% of the individuals. If we see the distribution of suicide due to profession, a daily wage earner recorded about 25% of the death, then followed by housewife, that is 14%, self-employed person 12%, salaried persons 9%, unemployed 8%, and the students. There has been significant increase in suicidal rate in students, which is about 8%, farming sector 6%, retired elderly people 0.9%. So majority of the individuals are in the low income status, that is daily wage earner. If we see the suicide victims by social status in India, majority of them are married. So the majority of social status come the marital criteria, both male and females, followed by the unmarried individuals, divorced and widowed. When compared to the profession, when compared to the years of education, the primary level of education reported 15%, middle 19%, matriculation 24%, higher secondary 16%. So professionals, graduates and diplomates, they have lower number of suicide, which is the strongest protective factor. So literacy can be the strongest protective factor against suicide. If we see the means, the method of suicide, from the year 2017 to 2021, the commonest method being hanging and poison, which is more than 75%, followed by third important one is drowning. When we see the city's contribution to the suicidal share in India, from the year 2018 to 2022, almost majority of the contribution are from the cities, that is almost 15%. And when compared to the previous year, there is 8.8% increase in the contribution of cities in the suicide data. So death by suicide is a public health issue. That is almost 1 lakh death by suicide per year. And that is 449 death by suicide per day. That is 18 death per hour. That is 1 in 192 seconds. So it is an alarming epidemic, and we have to find some ways to prevent suicide. So when we see the prevention of suicide, though suicide is an individual decision and only that person can reverse the decision, but however, a friend, a volunteer, a family, or other human being can help that particular individual to prevent suicide. As because suicide is not an instant process or reflex, it is a process, it is a highway. For example, if an individual today goes through a feeling of hopelessness and despair, then he goes through the feeling of life is not worthless, depressive cognition. There is a passive wish to die, there is suicidal ideation. Then he plans how to die, where to die, and what are the what are the precautions that he won't be saved, followed by a suicide attempt, and there is a complete suicide. So we have several other routes or intervention ways where we can intervene in this process and help an individual who is feeling hopeless and despair. So when we see the level of prevention, it can be divided into primordial, primary, secondary, and tertiary prevention. Primordial prevention is universal, that is teaching basic life skills, lifestyles, and emotional well-being to the society as a whole. Primary prevention is mostly to address the high-risk individual, that is family with a strong genetic or family history of psychiatric illness, family with domestic violence, history of sexual abuse. We have to identify at-risk individuals and intervene appropriately. Or at the secondary prevention, a patient is having psychiatric illness, severe depression, having suicidal thoughts, where we have to intervene appropriately to prevent a suicide attempt. Or at the tertiary prevention, where an individual has already attempted for suicide, and we have to channelize him or intervene appropriately so that he don't reattempt again. So prevention of suicide is a multi-dimensional problem. It's a biopsychosocial problem. Similarly, the prevention of suicide is not an unidirectional or an individual responsibility. It is a collective responsibility. So here I will be briefly categorizing into responsibility of that particular individual, responsibility of the community, the responsibility of the healthcare professional, particularly about the role of media and the national policies and programs. So at the individual level, what you can do to prevent a suicide or to help an individual with suicide. Every individual in the society has to undergo a gatekeeper training. That is, they should be trained in appropriate way to pick up individuals who are at high risk of suicidal tendency, to identify people who is having suicidal thoughts or depression, proactively inquiring about the symptoms, persuade him to treatment, and refer them to appropriate treatment facilities. Every individual should undergo psychological first aid program to understand about the psychiatric illnesses and to pick up the risk factors and warning signs. As an individual, you can join a helpline or a crisis intervention line to help an individual who is having suicide ideas. As an individual, you can support each other who is in distress, and particularly we should not stigmatize or discriminate an individual who is having a mental illness or who is on medications or who is from the minority groups like transgenders or the migrants or the employment and unemployment individuals. So as an individual, you have an important role in preventing suicide. In the community level, what one can do to prevent suicide? The first and foremost important thing is improving the well-being in general. That is improving the employment status, improving the education status, and decreasing the economic deprivation. The important thing in the community level is we have to promote mental health education, because though the treatment facilities are available, the major barrier is that the public don't have a basic understanding about a psychiatric illness or when to seek help. So only if we make available awareness about the mental health issues, the risk factors, and the warning signs, then only at the community level people will be able to approach the treating team. We have to encourage help-seeking behavior. When an individual asks for help or expresses suicidal thoughts, it should be considered as a sign of strength rather than being ridiculed or brushed away. And this can be done only by reducing the stigma against the psychiatric illnesses and the patient. This can be done only by an open conversation among the community, among the members, or you can share your personal stories or your family member stories so that the other patients, they trust confidence on you and they come readily for treatment, and thereby it can reduces the stigma to a psychiatric help or treatment. The other important barrier is about the financial need, because we have seen that economic deprivation is a major risk factor for suicide. So at the community level, one should microfinance for people in need. The most important thing is decreasing the means to harm, because majority of the suicides in India, the mode of death is by hanging, poison. There has been a particular studies which have been undertaken regarding the farmers' suicide through pesticides. They've adopted certain villages where the farmers, after farming, they come to the pesticide bank in the evening. They drop their pesticides and then they go back to home. The next morning, they come back, they collect the pesticides and they go. So after a follow-up of 2 to 3 years, they have found that significantly the suicidal rate has come down in that particular village, which has adopted this mechanism. The main reason behind that was they don't have the access or means to end their life, and during that time they can access the healthcare services so that they are able to come out of the suicidal thoughts. The other important thing is over the counter prescription. Many individuals who are on psychotropic medication, they consume the medications in an enormous amount. So at the dispensary level, we have to make sure that over the counter medications without prescriptions are not available. And if any person or individual asks for a large amount of medication in a suspicious manner, they need to be understood, persuaded, and appropriate referral should be made. Other important thing is we have to enhance the access to the care, as because majority of the mental health care services are not available to everyone. So we have to make sure that all mental health services, including counseling, therapy, support groups, they are available to everyone. The psychotropic medications are available free of cost at an affordable and a convenient way. And the important risk factor in suicide is alcohol. So there should be stringent, effective, and restrictive alcohol policy so that high-risk groups and families, they don't have more access to the alcohol, and thereby the death rate can come down. And the important thing from the primordial level is school and college program and workplace initiative. That's because the students' death has been increasing over the last years. So there should be a student or college counselor made available in all schools and colleges. And if an individual is in distress or stress, they have to contact the counselor immediately. And appropriate stress management programs, life skill programs have to be conducted in every school and college level. Same goes with the workplace initiatives, where the stress management programs and the resources for the employees to seek help are readily available. And there should be lots of support groups. It includes training of all Anganwadi, ASHA, and A&M workers about the psychiatric illnesses and how to pick up suicidal patients and high-risk patients. All school teachers and college teachers should be trained in mental health, and all the graduates should undergo compulsory training in mental health. There should be massive community awareness about the suicide and mental illness, and all healthcare professionals, apart from the psychiatrists, they should be involved in the prevention of suicide. So there is another peer-to-peer support network where survivors of domestic violence or a group of students or sexual abuse survivors or transgenders, the leader should be identified as a volunteer or a champion in that particular group, where they support each other. Make an help to them, and if needed, they refer to an appropriate psychiatric or counseling referral. So peer-to-peer support group is in the community is a major self-help supporting group in the prevention of suicide. The next foremost important thing is about the teleintervention and crisis helpline. If we see the teleintervention has been almost there since 1986. So there has been detailed so many teleinterventions. Some of them are central, starting from Sneha, Susmaitri, Asha in 2003, 108 as Pan-India Helpline in 2005, to Wonderwall Foundation 2009, iCall by 2012, 2013 Arogya, 2020 Kiran, the first centralized helpline, and 2022 is the Telemanas. This is a centralized helpline. There is a toll-free helpline number available in different languages. If the patient is in acute crisis, suicidal, or you are not able to bring in violent patient, you can call the toll-free number and you can get appropriate help properly. So this has come a long way. This is getting so many calls in a day, and the number of they have identified individuals with suicidal ideas, and the rate of they're trying to decrease the rate of suicide attempts. And the next most important thing is technology-based support. As because due to understaff and no proper access to the mental health, this technology has come a long way in supporting individuals, particularly who are in the remote place, particularly telepsychiatrists, by using social media for supporting high-risk population, by offering therapists and counseling using artificial intelligence, or to develop wellness application and suicide prevention apps, which where an individual can assess themselves about whether they are depressed or having suicidal thoughts, and what are the preventive strategies, meditation techniques, and whom to contact. So though there has been numerous studies on this, the a number of scientific papers are yet to come about the telepsychiatry and its role in suicide prevention. The next foremost important thing is focusing on the high-risk population, because again and again we are seeing individuals who are previous attempters, they are constantly attempting suicide again, and individuals who are using alcohol and domestic violence and environmental factors. So it should be made available that almost all districts have a de-addiction center to help individuals who is having alcohol problems, and rehab center and psychiatric facilities should be available in all district hospitals. And in the society where there is domestic violence and marital issues, family counseling centers should be available. Fair price for farmers to cut down the suicide rate among the farmers, and to improve the support groups for the vulnerable individuals. Coming to the role of healthcare professionals as a psychiatric or what you should do is you have to train all PHC workers in identifying the common mental illnesses, and to identifying people who are having risk factors for suicidal thoughts, and making appropriate referral or intervention treatment there, which is feasible at that moment. And aftercare for those with high suicide risk group, like if a patient has attempted suicide, we need a frequent follow-up at least for next to 1 year with the patient and as well as with the family. And the major contribution is promoting mental health awareness in the public to reduce stigma and offering help. And we have to make sure that the public understands that the depression is treatable and suicide is preventable. So responsible of the media. So media plays a significant role in suicide, as because this is a particular study. This study reports that when the headlines or the first paper, there is a report on the suicide or on the methods used, they have found that the risk of suicide increased by 13% in the period whenever there is an article in the front page about a particular celebrity committing suicide. And particularly the method followed by the suicide victims were almost the same as the celebrity has used. This is called as Brither effect. The Werther effect is based upon a novel where that particular character Werther, he was feeling depressed after he was not able to marry his love due to socioeconomic status, and he ended his life by suicide. So after that novel, so many people in Europe, they ended their life by suicide. Particularly, they were having the particular book at the scene of crime, and they were wearing the same costume as that of the Werther. So this has been a Werther effect. There is a negative aspect of the media of how not to portray the celebrities in the or to make news sensational. There is also a positive aspect of the media. The media plays a significant role in increasing the public awareness about the mental health, what is suicide, how to identify the risk factors and the warning sign, to display the helpline number constantly whenever an individual is in distress. And the media should not glorify or sensationalize a celebrity suicide. The media should not describe in details about the method used or the personal details, because the survivors of that particular patient, the family members, they will also be depressed. And the media should follow the national press guidelines of how to print or visualize the data. If needed, they have to consult the expert, maybe a psychiatrist, of how to report that particular news. This is called as the Papango effect, where in the opera, the magical flute that was depressed after losing the last one, Papagno, and the two boys, they came to the help of this one, and he was able to go into a positive adaptive lifestyle and came out of that suicide. So based upon this particular thing, studies have found that in several stories, when there is a positive approach to depression or suicidal thoughts, there has been significant reduction in the incidence of suicide. So medias and play a significant role, both in print as well as visual, in cutting down the rate of suicide. So what we have done as national initiatives, the mental health policies and programs, it starts from 2014. This was the first policy to create awareness about destigmatizing mental health issues, and it also gave importance to addressing substance use and dependence. Followed by the National Mental Health Policy, the suicide prevention and awareness has been a part of many other national programs like Ayushman Bharat Health and Wellness Centers, Pradhan Mantri Jan Arogya Yojana, where there is a health assurance scheme for a coverage of mental disorders, among other diseases, and 17 packages for mental health disorders. It includes facilities like ECT, RTMS, and investigations. The suicide prevention has also been part of national program for prevention of
Dr. Uma,
non-communicable. Yes.
I would request you to wind up as
Yes,
we are getting
yes.
closer to the time. Yes,
Yes.
thank you.
So the mental health promotion has been a part of School Health Ambassador Initiative, where 2 teachers will be identified in the government schools, and they will act as ambassadors in the promotion of mental health and well-being. The important significant milestone is 2017, where the 309 IPC Penal Code that was eliminated. That is, decriminalization of suicide was done, and the suicide victim were offered help from the government side as well. So the recent update, as Sarah has discussed, is mainly about the National Suicide Prevention Strategy, and Dr. Lakshmi Vijay Kumar is a particular contributor for this National Suicide Prevention Strategies. So the main pathways are to reinforce leadership, to enhance the capacity of health services, develop community resilience, and strengthen surveillance. So almost all governments are involved in the suicide prevention strategy, from the central government to the volunteers, educational institutions, families, and individuals. So suicide is a public issue. It's everyone's responsibility to prevent suicide. The current suicide are only tip of the iceberg. So data should be captured under the National Disease Surveillance Program, which should facilitate better understanding of the burden and risk factors over time. A comprehensive community surveillance system using third-party informants can add value to the existing data from hospitals and police, and possible and address the underreporting of the NCRB. So more research are there on the suicide in the recent years, but less number of research are into the biological and into the preventive aspect of the suicide. So this has to be improved. Thank you for the opportunities.
Thank you, Dr. Umamaheswari, for that
Yes.
exhaustive deliberation on suicide statistics in India and the various intervention strategies that can be used to control suicide. So we'll not take any questions now. We'll move to the next speaker, and at the end, we'll take questions. And once again, I'll remind all participants to put their questions in the chat box. I don't see any questions yet, but please feel free to post your questions as the session goes on. We'll take them up at the end. So now we'll proceed to the second speaker, Dr. Pradeep. He has done his MBBS from Thoothukudi Government Medical College and MD-Psychiatric again from PGI Chandigarh, and he was a bronze medalist in the MD exam. He has worked previously as an associate professor of psychiatry in Vinayaka Mission's Kripananda Warrior Medical College Hospital, Salem, and presently he is consultant psychiatrist in Dharan Multi-Speciality Hospital, Salem. His areas of interest are acceptance and commitment therapy, about which he's going to talk today, specifically with respect to suicide and suicide prevention. And other areas of interest include student mental health and psycho-oncology, all of which are relevant to today's discussion, I suppose, and he has also published in these areas. So over to you, Dr. Pradeep.
Thank you, sir.
Yes, Doctor. Screen is visible.
Yes, sir. So good evening, everyone. So at the outset, I thank Dr. MD-Salem sir for the opportunity, and other members also for the opportunity given to me to speak about this topic, the role of acceptance and commitment therapy in suicide prevention. The first 2 slides I will be describing about how ACT. Again, I will mention acceptance and commitment therapy moving forward as ACT. So how ACT looks at suicide and how, in a generally, we try to handle suicidal behavior with ACT. And next 2 slides, I will explain the same, how it works out if the case example. So that's how this presentation is going to be. So the vicious cycle of suicidality, how acceptance and commitment therapy looks at suicide. So suicidal behavior is seen as a learned response. So what happens is there are different situations which a person finds it difficult to handle. And there are a lot of private experiences in the form of difficult thoughts, difficult emotions, difficult sensations, urges, impulses, which show up in response to these difficult situations. So what happens is a person when a person starts interacting with these experiences in the form of perceptions like, oh, this is bad, these experiences are bad, this situation is bad, oh, I cannot handle it, I cannot tolerate it, this is more than me, this is overwhelming, I should not have these experiences, thoughts, emotions, other experiences, and I should not be in this situation. There is something terribly wrong with me because of which I am having all these experiences, and there is something wrong with me that I am not able to handle these situations, these private experiences in a better way. So once this kind of perception sets in with respect to these experiences, or these experiences and these situations are seen as a threat. And we all know whenever we are faced with threat, our mind responds with fight or flight response. Either destroy those or get rid of those private experiences, those situations, or run away from those private experiences, from those situations, something which we call in acceptance and commitment therapy as experiential avoidance. So experiential avoidance, just remember the term, this is a transdiagnostic process. So most of the disorders can be explained in terms of this experiential avoidance. I will get back to it in a short while. So this experiential avoidance, once this experiential avoidance sets in, 2 different things happen. When we try to when we get into this fight or flight mode with respect to this private experiences, what happens is a paradoxical effect. Rather than these experiences reducing, it has a kind of effect like as if in a swimming pool, there is a ball, you just push the ball under the water and it rebounds with equal force or more force. So that's the kind of thing which happens with these private experiences. The person starts feeling or getting increased frequency, increased intensity of these private experiences in the form of thoughts, emotions, sensations, urges, and impulses. So person gets more of it, and once they are already afraid, already they're seeing these experiences as threat. So once there is increased in intensity and frequency of these experiences, so the threat perception increases little bit more, and all this threat fight or flight response increases more. So this is the kind of vicious cycle person gets into. So once this vicious cycle gets into, and again another aspect, apart from this paradoxical increase, another aspect which happens is lot of things in their life, they remind them of those painful experiences, so they start avoiding a lot of things, which again you will understand better when I get to that case example. And they involve in what we call as life costs. So they involve in substance use behavior or avoiding all the things which were protecting them so far, acting as coping mechanisms. They start avoiding all those things. So what happens because of this, because of the life cost and the paradoxical effect is, after some time, person gets into a mode where these problematic situation appear as intolerable, interminable. It's not going to end at all, and inescapable. No matter what I do, maybe I get short-term relief, but ultimately my life gets worse. So this is the kind of 3 I's which develop, which leads to, and person starts thinking, okay, these situations, these physical, that is private experiences, suicidal behavior is the only option for me to respond to them. So that's how it becomes. So when one person engages in suicidal thinking or suicidal behaviors like cutting or hurting themselves or even suicidal thinking, they get a kind of temporary relief out of it. Okay, I am finally I can get rid of it. I can get away, get rid or escape from these private experiences and these situations. Even thinking about it can give a temporary relief, which perpetuates. We know that ABC response, antecedent behavior consequence. So behavior of suicidal thinking or suicidal behaviors give a short-term relief, which keeps the behavior going in response to these kind of antecedents and situations. Just moving on, how acceptance and commitment therapy. In acceptance and commitment therapy, what we generally try to do is, with any therapy, it deals with ABC, antecedent, behavior, and consequences. So in acceptance and commitment therapy, what we try to do is these antecedents. We find different ways. There are 6 processes or different, we can call them as processes or techniques or ways of interacting with antecedents, the difficult situation and the private experiences, and also 6 different ways of interacting with the consequences, so that these experiences are not seen as a threat. These experiences are seen, they are not seen as intolerable, inescapable, or interminable. So they are more, we can call more like they are less aversive. Initially, they are more aversive. Now they become less aversive, or in some cases, even they can become competitive, these private experiences or the situations. So, and also the other, so that the person can engage in different behavior in response to these situations, and they can face different consequences. And also the aversiveness or appetitiveness of the suicidal behavior is reduced through using those processes, 6 processes or 6 ways, and appetitiveness of the alternate behavior is increased. So this is how acceptance and commitment therapy looks at suicide and tries to handle suicide. So let me come to a case example, client example I was seeing. So patient is a 28 years old female. She is single, pursuing her PhD in a foreign country. She presented with complaints of, I have not done a detail, I have not put in a detailed one, so just bear with me. So the background of these symptoms were during the initial COVID period, first COVID period, again, she has a boyfriend. So initial COVID period, she had some physically intimate moments with another colleague. So following that few intimate moments, so another following that, she started getting this shame, guilt, what we call moral injury. So she suffered a moral injury, which started appearing in different situations in the form of feelings of hollowness, neck and shoulder pain on and off, reduced sleep, when cognitions like, I have everything in life, there is no reason for me to have these thoughts and emotions, I'm a horrible person, I cannot live with myself, I don't deserve to live. Once she got into a vicious cycle, it even turned into suicidal ideations. So this was happening over a 2-year period. So let me explain in a little bit more detail her case with help of this hexaflex thing. Hexaflex is what the 6 processes I was talking, or 6 ways of interacting with the private experiences. So I will just start with this again, experiential avoidance. Experiential avoidance is where we try to change our private experiences in the form of, in either form, frequency, or intensity. So that is experiential avoidance. So what this patient was trying to do was, she was initially trying to work more. She was involving more and more research, spending more time in research, so that she need not have face this shame, guilt, all this hollowness, pain. So what happened was, slowly what happened was, her work, these experiences found her even at work. So now work became aversive. So she started working less. So since she started working less, she started having less consequences, less positive consequences of not working, and this extended to many other events. She stopped listening to songs, she stopped watching certain videos, certain movies, she stopped interacting with friends, she stopped even strangers started eliciting these private experiences, these memories and private experiences in her, to the extent she started just remaining in her place. And then she thought, okay, this is not done. I may do something to myself if I am here. So she came back to India, and the same cycle repeated again. She thought, okay, if with the family, I will be able to be good. I will be able to improve. So she was with her family, partying, trying to go out, but still those experiences found. Even happy moments were suddenly followed with or attached with these difficult experiences, and she started avoiding all those things. Her friends for life, she was avoiding them. Shopping, she used to like, she was avoiding them. Literally, it was like she was confined to her place. So that is the kind of experiential avoidance, these we are talking about. So we tried, again, when she came with this kind of experience, I tried acceptance. Acceptance is more like if you have a wound, just taking care of the wound till it heals. So it's like a psychological wound has happened. So I take care of the wound till it automatically it heals by itself. So that's the basic funda behind acceptance. I give it time, and any wound, it heals by itself. All we can do is apply some balm. We can just be gentle with that part of the body which has wound. So that's basically how acceptance works. Just allowing those experiences to be there till they become less threatening. They stop being a threat. So that is how acceptance works. So we use various techniques like noticing those emotions, naming those emotions, something called physicalizing. We try to ask them how what color those emotions are, how deep it is, what kind of form and shape it would take if it was in an external world. So those kind of questions helps them get more accustomed to those emotions or experiences, sensations and emotions. Because of that, they're able to, or these experiences become less aversive. So that's what we try to do. So with this patient, initially when I tried it, it was not working. So this is one way of interacting with the experiences. So next, let's come to the present moment awareness. Present moment awareness is a process where we are aware of whatever is happening around us and whatever is happening within us, whatever information we're getting out of all our senses and whatever is happening within us, just be aware of all those things. So what happens with this patient usually is, whenever she is in a situation, she will be suddenly reminded of this experience, this private experience. Somehow, even in a best moment, she finds these experiences, these memories come. Once these memories come, she jumps into the past, goes to the future, and then all those ruminations and worries start kicking in. And all these hollowness and other private experiences start bubbling inside or increasing inside. So that is, again, what present moment awareness or no present moment awareness does. So usually we use something called anchoring techniques and body scan to handle it. Again, this initially it was not that much working with the patient. So let's come to cognitive diffusion and fusion. Cognitive fusion is simply taking our thoughts for literal truth. What the kind of judgments our mind give, the reasons, the self-explanations, whatever our mind says. So we interacting with that part, interacting with our thoughts or that private experience as if it is a literal truth. So that is what cognitive fusion is. Again, she was fused with the thoughts, or she was interacting with those thoughts like, I'm a horrible person, I don't deserve to live, I am morally not a right person. So these kind of thoughts she was interacting as if they are absolute truths. So that is fusion. Diffusion, cognitive diffusion is when we look at or we interact with those thoughts as if they are just simple words, images. So that's how we try to interact with the thoughts in cognitive diffusion. And most common technique we use is leaves on a stream. So leaves on a stream. Again, this was again tried initially with the patient. It was not again working. So values and committed action was somewhat combined. So values is what we want in life, what kind of person we want to be in life. So she had her values, clarity was there. She wanted to pursue PhD in research, and she wanted to create certain name for herself, be a certain type of researcher. So her values were good, but unfortunately, because those work and other research works were reminding her of the shame and guilt, she was not able to access those values. So when we try with different techniques to get in touch with values, and again, it was initially not possible with it. Committed action, when it comes to committed action, it's anything, any process we use to interact with those experiences, it's called committed action. So we'll get to that later. Then comes a self as context process. So self as context is the ability to shift perspective in terms of time, place, person, and also ability to look at these private experiences as if they are just part of us, and the whole is more than those parts. That is, we are more than those experiences. Just these experiences are not us. These thoughts, private experiences, these situations are not us. We are more than that. But she had this thing that I am a terrible person. I am not fit for living. So that's the kind of self thing or these experiences she was starting to relate to those experiences in that way. So this is an important process because this is where her things started changing. So what happened was, we try to look at, when other processes were not that much working, we try to look at her past and the person, the timeline when she was actually engaged in those physically intimate moments, and what other things she was doing at that time. So what happened when we did that, she was able to shift into those different aspects, shift perspective in terms of time to the past and place, person. What happened was, she started looking at that person who engaged in supposedly morally injurious activity. She started becoming more compassionate towards that person. She started looking at that person in a more compassionate way. She understood that person for what she did, what was the circumstances. She understood that better. So she started feeling more compassionate towards her. So once this door opened, what happened was, more she started having these private experiences, these difficult memories, these thoughts. She started using that compassion towards these experiences. She started displaying more compassion and understanding towards these experiences. So what this did is, it opened up all other doors. She was able to now use that present moment awareness more in terms of those experiences. She was able to tolerate or give room to those experiences, those private experiences in the hollowness or those shame and difficult thoughts. She was able to use other diffusion techniques in a better way. So when she did all this slowly, she was able to get in touch with her values of good relationship with her boyfriend, and value of her work, all her work she had put in. So she started doing more of those now. She started seeing her friends. She started engaging in, and whenever she was seeing friends, whenever those memories and thoughts were coming, she became more self-compassionate. She started using other activities, those songs and videos. She started slowly, we started exposing her to all those things, and she was practicing all this compassion and other processes, other ways of interacting with those experiences. So slowly, those suicidal ideations, she need not engage in those suicidal thinking or suicidal behavior to handle these experiences. And just a moment, just a minute, I just have a minute of presentation. So once she started interacting with these experiences better, she went back. She started again. Once she went back, work is something she was avoiding before, and those experiences are coming. So we exposed her to her work, and we did those this compassion and other processes we just practiced. And once she got connected with the positive consequences of working, these private experiences stopped coming. And even in other people, their friends, family, with every person, once that exposure and these processes, these different ways of interacting with those experiences came, she improved. And so this is how acceptance and commitment therapy works. We just find different ways of interacting with our private experiences and the situations so that we can have the kind of life we want. So this is the direction in which this acceptance and commitment therapy works. So again, I was just going through the notes and that breakthrough session, which happened, it was in last September. So we are just completing September 19, I think 19, 20, we're completing 1 year of follow-up, and she has been maintaining well. This to the extent that last month she sent me a video. She did in a European country, most reputed university. She had done a research presentation.
Dr. Pradeep, we'll need to wind up now.
Yes, sir. So that's all I have to share with you. Thank you.
Okay. Thank you. Now it is open for questions. First, we'll take up, there are 2 questions in the chat box. I think both are for speaker 2. So if you can take it up, Dr. Pradeep. The first question is by Dr. Giridhar Shivaji.
Sir, can you read the question, sir?
Yeah. I'll read it. Or I think this question is it's not addressed to which speaker it is, but I think it is to speaker 1 then, because they are mostly talking about suicide. I'll just read it out. Hypothetically, if a person is a daily wage earner and sole breadwinner and he has to support his family and he gets severe physical illness, since most suicidal population is daily wage earners, I don't think antidepressants or therapy will help. I think maybe government should give everyone a basic income so that they're not pushed to flight or fight mode, as academicians should nudge the government to do a study on this and experiment on a village. I think it's related to suicide prevention pointers that Dr. Umamaheswari discussed. So,
Yes,
Dr. Uma, would you like to take up this question?
Yes, sir, definitely, sir. As we know, suicide is multidimensional. It's not only the biological thing, it's more to do with the environment as well as the psychological factors as well. Since this particular case about the daily wage earner, he has economic deprivation, so this leads to depression and suicide. So in the suicide prevention, it is not about only the Department of Health or the Department of the Family Member. It's almost all departments, all health policies, they have to work in collaboration to cut down the rate of the suicide, and thereby it should be addressed to the department of, I don't know which department will come, sir, about poverty, maybe Department of Health or Family Member, to eradicate poverty. Government has been trying on, like they're giving housing allowances, housing schemes, and supply of food. So I think the government should work more about improving the economic deprivation, and thereby it can lead to the occurrence of depression and suicide can decrease.
Yeah, thank you. I think you also mentioned in your presentation about
Yes.
the need for economic support and how economic policies are also, to be formulated to reduce suicide. Okay. Then we have a question to speaker 2. That is from Dr. Satyamurthy. I'll
Yes,
just
sir, I
read out
can
the
see the
question.
question, sir. Yes, sir,
Yeah.
I saw the question. So my response would be, yes, sir, you are right. Definitely genetic susceptibility is there. As Dr. Umamaheswari madam just told, it's a biopsychosocial thing. So genetic, definitely we won't be able to take care as of genetic as of now. Maybe with medications we can do something about it. But psychosocial factors, that's where these therapeutic techniques come in. So even when there is a genetic susceptibility, we just follow the same kind of model to handle the people, handle the suicidal behavior. So I hope that answers sir's question. And I can see another question.
Yeah, there are 2 more questions in the chat box. With that, we can probably try to wind up. If both are addressed to you, Dr. Pradeep.
Dr. Abhinami said, what's the role of ACT in patients with repetitive suicidal attempts? Again, madam, I've seen few other patients with such a case history. So the modes of responses or the therapeutic techniques are the same. The thing is, I've not talked about crisis management and all, which usually we all of us know. So, but all those general techniques which we follow in other therapeutic techniques, we follow in here also. And this kind of patients, there may be, we may need those kind of techniques also. So that's what I would respond to this. So at least some 4 patients I was able to handle with the same kind of techniques. Again, in ACT, what is not every patient responds with self as context. Not every patient responds with, so the kind of breakthrough comes from different directions, and whichever direction it comes, that will just generalize to other processes and other factors. So that's what I would answer.
Yeah, the last question is whether it works in adjustment disorders.
Works mostly in adjustment disorder. Again, sir, I won't simply the kind of people I was talking about. We can many of them can be put into this borderline personality disorders and other personality problems. And one of the patient I kind of handled, that person definitely had severe depression. So along with other modes of treatment, acceptance and commitment therapy was also done. Again, it was Dr. Uma's patient. She was the one who gave the opportunity to work. So it's not only for adjustment disorder. It can, again, experiential avoidance is a transdiagnostic process, and the processes works in many. Again, recently we kind of we may be publishing shortly in our ward schizophrenia patient who is not having full relief with hallucinations. We helped him handle those hallucinations with acceptance and commitment therapy, and he is working for the past few months. So it's not simply just adjustment disorder. It can work in multiple levels, multiple different DSM disorders.
Okay, in the interest of time, I will now, I think Dr. Nurul has raised his hand. Dr. Nurul, you want to come in at this point?
Good evening, everyone. Good evening, sir. Good evening, speakers. So I have a question. So in the spectrum of OCD, so we have a type called aggressive OC type. So in that type, so how frequently that OC ends up in injuries or any fatalities? So any data or any understanding about that, sir? Because when a patient comes with the aggressive type of OC, how severely we have to take further steps in order to prevent that? So just throw the light on that.
Any of the speakers want to respond? It's open. Anybody wants to respond to that?
Sir, unfortunately, the amount of OCD patients I get to handle with acceptance and commitment therapy is very less. So I won't be the kind of expert to answer for that.
So from whatever little I can add to this discussion, like I think the question is on how common are aggressive behaviors landing up in risk of harm to self or others in OCD behaviors. So I think what the data shows, from whatever I can recollect, is that aggressive obsessions are present in about 10 to 15% of individuals with OCD behaviors. And a fraction of that, I think less than 5% would be involving risk of harm to self or others. There's a need to distinguish between ego-syntonic suicidal thoughts and ego-dystonic suicidal thoughts, because when you're actually having ego-dystonic suicidal thoughts, the risk of harm to self may be less, because there the concern is more about why am I having these thoughts rather than actually the patient having the risk of carrying out those thoughts. So I think these distinctions need to be made and appropriate management plans to be prepared. This is what I can add. If anybody else wants to add to this, please feel free. Otherwise, we'll wind up with that.
Dr. Pradeep, I have one question. What,
yes, sir.
That acceptance commitment therapy, other than suicide, what are the conditions used for? I think recently that a lot of people are talking about this acceptance and commitment therapy, mindfulness, DPT. These are all gained momentum in recent years. Once upon a time, we used to talk about this psychiatric therapy, psychoanalysis, a lot of other therapy was there in the past. But nowadays, recently, people are more focusing on this ACT, mindfulness, and DPT like that. So what else it used for other than this suicide prevention? This acceptance commitment therapy.
So most of the conditions in which we use traditional CBT techniques, acceptance and commitment therapy has been tried, sir. Meta-analysis, if you see meta-analysis, it has shown equal effect in terms of depression, chronic pain disorders, and anxiety disorders. And in chronic pain, they even those meta-analysis show it is little better than even traditional CBT. So most of the conditions in which CBT has been tried, this acceptance and commitment therapy is being used. So a lot
Even
of
for OCD, sir. Even for OCD also, the American
Yes.
Psychological Association recommends
Yeah.
ECT for OCD also.
Oh,
OCD panic, the kind of patients I see mostly are panic disorder patients, personality disorder patients, and depression. So these spectrum of patients, some OCDs are not much, but this anxiety disorders, depression, personality disorders, these are the spectrum I get to see more. And it helps a lot of people.
Sir,
So,
one more, Dr.
yes,
Natarajan, one more explanation for that OCD aggressive obsession. Actually, that is actually safeguarding to others ourselves, because in OCD is ego dystonic. Especially one example I want to give: postnatal mothers, if they develop aggressive obsession, they avoid to touch the baby because I will harm the baby. So though there is aggression is the thought, it is ego dystonic. There won't be any harm to the self or others. It won't happen. But when it is delusion, then we have to fear of that. Thank you.
yes. Thank you, sir. I think we are at 9:20 and the attendance is slowly decreasing. So I think it's now time to call the webinar to a close now. I will invite Paneerselvam sir to deliver the. I think Ramakrishnan sir is not there, I think, in the meeting.
yeah.
Yeah, so I will invite Paneerselvam sir to give the concluding remarks.
Thank you, Dr. Vikas. I congratulate both the speaker for their excellent deliberations. There are more than 95 participants who are there till the end of both the speaker presentation. It shows that the quality of the importance of the topic and quality of the speaker. I think it's I congratulate both the speaker. And as per the speaker information, I understood that the current suicide rate in India is more than 12%. I think it's above the global average. I think so. So suicide prevention is a multi-model which should involve the individual as well as the community. And one has to follow the suicide prevention strategies like promotion of mental health, spread awareness about the suicide, reduce the stigma, and also we have to increase a social support network, which is an important thing for the suicide prevention strategies. And also the responsible media reporting guidelines. That's another important issue for the suicide prevention. And also we need to have an acute interventions, and as you use the therapies like Pradeep said, the acceptance and commitment therapy, all the things we have to use to prevent the suicides. So I request these all our TNIPS member to spread awareness about suicide prevention, and I'd be happy if you upload your photos and the work done regarding the suicide prevention activities, because the coming week is a suicide prevention week. So World Prevention Day and September 10th, and 1 week following that 1 week is a suicide prevention week. So I'd be happy if you upload your photos and work done regarding suicide prevention in the WhatsApp group or our TNIP website. I'd be very happy. So thank you all. Thank you all, the scientific committee, Dr. Vikas Menon. Thank you all for a nice, this successful of this first webinar. First webinar, I think it's a very grand success. I hope the scientific committee will continue to do this work in subsequent months after. Thank you very much.
Thank you very much, sir. We'll surely try to live up to your expectations. Now I will call Dr. Nurul Hassan to deliver the vote of thanks.
Thank you, sir. So, there is a Thirukkural, Gopatalai Kudi, Ulla Piridal, Anaithe Pulavar Thulil. The ignition of hope in the minds and creation of longing feel in the hearts are the attributes of knowledge-centric gathering, says Thiruvalvar. I hope this session deserves such a title. And the Tamil Nadu chapter of Indian Psychiatric Society owes a great honor in effectuating the first webinar of the monthly series in the new presidential period under our most respected Dr. C. Paneerselvam sir. Our sincere gratitude for your foresight and its flavored leadership. I thank Dr. Sabrine Rose, Vice President of TNIPS. I thank Dr. MD-Salem, Treasurer TNIPS. I thank Dr. Sivalango, Secretary of TNIPS. And I'd be privileged to express my gratitude to Dr. Vikas Menon, sir, for wonderfully moderating the session. Most importantly, I thank both the speakers, Dr. Uma and Dr. Pradeep, for the wonderful deliberation. I thank all my senior office bearers of TNIPS and my dear participants. Thank you, and all. Thank you. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you.
Good night.
Thank you.
Thank you. Thank you.